Yes, sir. Good afternoon, esteemed guests, speakers, and participants. Welcome to our Tech Talk webinar on targeting mobile and migrant population to prevent malaria reintroduction. I'm Professor Xiaonong Zhou, the Chief Scientist in the China CDC, based in Shanghai. As you all know, the APMEN stands as a beacon of the cooperation across 22 countries, fostering connecting among national malaria program and the partners institutions in our region. So this webinar is a part of the APMEN Tech Talk series, dedicated to the advancing knowledge exchange on critical technical areas, and is hosted by Surveillance and Response Working Group, for which Professor Richard Maud from the Mahedo Oxford Tropical Medicine Research Unit and myself are currently serve as the co-chairs. So today, we focus on the challenge of targeting mobile and migrant population in malaria elimination efforts. This population poses unique challenges due to their mobility and the behaviors, which contribute significantly to sustaining transmission. Our esteemed speakers bring invaluable experiences and expertise on this issue. Our talk series begins with Professor Dr. Palakash Gimira from the Tribhuvan University in Nepal, and joined by the UCSF's Malaria Elimination Initiative team. Together, they will share insights from Nepal on strategies for addressing imported malaria. Second one will be the Professor Wang Duquan from the National Institute of Parasites of China, CDC. He will deliver on the China's innovative grid-based surveillance strategy in high-risk border communities around the Vietnam-Myanmar border. Lastly, Mr. Living Vernavi from the Malaria Consulting will discuss targeted malaria interventions by mobile malaria workers in Cambodia. So we are truly fortunate to have such esteemed experts among us, and I'm confident that their presentations will spark insight for discussions and inspire actionable solutions. Before we dive into the presentations, we encourage all the participants to actively engage in the discussion, share your thoughts, and leverage this platform to exchange ideas and best practice. Last but not least, I extend my sincerely grateful to our distinguished speakers for their invaluable contributions, and to all of you, our esteemed participants, for joining us in this crucial conversation. Together, let us embark on this enlightening journey towards the preventing malaria reintroduction. Thank you. Thank you so much.
Thank you, Professor Zhou, and welcome everyone. So I'm Richard Maud, I'm the co-chair of the SRWG. I'm just going to quickly go through the meeting mechanics. You'll see already that the audio and video have been disabled for attendees. So we'd like to ask you to put any questions in the Q&A box, which you'll see at the bottom of the screen. There's a little icon with Q&A beside it. And then if you've got comments, you're welcome to put them in the chat box. So we'll be taking those throughout. We'll have the three presentations, about 15 minutes each, and then at the end we'll have the Q&A session when we'll go through your questions from the Q&A boxes. And if there's not time, then we'll also collate all the questions that everybody has put in, and we'll try and address those after the meeting as well. So we have about an hour and 5 minutes from now. Right at the end, there'll be a quick poll for feedback, so try and stay till the end if you can. So without further ado, we'll go to our first speaker, who is Dr. Prakash Gimira from Nepal. who's going to talk about characterization of imported malaria and possible strategies for elimination of experience from Nepal. Dr. Prakash, over to you.
Thank you, dear Cheers, Professor Zhao and Professor Richard Maud, APMEN team and others. Thank you for this opportunity. Let me quickly run through the presentation. I'll be discussing on characterization of the imported malaria and possible strategies for elimination, a Nepal experience. If you see Nepal in 1950s, we used to have almost 3.4 million cases with about 38,000 deaths. And there is a significant progress Nepal has made in the recent years with 74% decline in malaria cases and 98% decline in indigenous malaria cases in last 10 years. And more of the endemic districts are concentrated on Western Terai district lying close to India border. And the imported cases increased from 42% to 97% in the recent years, if you see these. And Nepal is a small country lying between India and China, two big neighbors. If you see the epidemiology with malariametric indices, we still have more Vivax cases as compared to others. And all other parameters are going slowly towards the end, while Vivax is still a problem. If you see here, we have reached to a point where 93% of the cases are imported, while about 7% only indigenous cases. If you compare last 10 years of where the risk comprises of, the upper map clearly shows that there were cases in districts lying on the southern border to India from east to west with more concentration on west. However, if you see now 2023 data, it's very few, but still in western lowland lying close to India. The current strategy is surveillance, effective vector control, universal access to quality assured diagnosis and treatment, government leadership and commitment, technical and managerial capacities. With this, we have reached to this point, and I'll come to the study which we did back in 2016-17 and finding of that. So what we did is we first did a formative assessment to inform study design. We analyzed a retrospective data from 2013 to 2015, and part two, we did a prospective analysis with a structured survey questionnaires, focus group discussions, key informant interviews. On part one, with a retrospective data, we analyze central registry, descriptive analysis, and we see what is imported cases, what does imported cases means to us. And we did primary data source check, spot check, consulted with local vector control inspectors on the gaps and discrepancies on the data. And we analyze using R and QGIS softwares. If you see here on analysis, we saw that imported cases are increasing from 13, 14, 15. Vivax cases are also increasing, and male percentage is higher than female. Then we concentrated on 3 target districts, Kailali, Kanchanpur, and Bardia. If you see the API gradually decreased between 13, 14, and 15 in all 3 districts. And if you see the concentration has also faded down in all these 3 districts, and the endemicity in 2013 has decreased in 2015. Then when we see API also decreased gradually. And we saw that the imported malaria cases increased while the local or indigenous cases decreased. And among the PF infections, 21% of the PF infections were imported in 2013, while 80% PF infections were imported in 2015. Then we went to part 2 of this, characterizing imported malaria cases and mobile migrant populations social contacts, which were done during August to November 2016. We enrolled cases, we tracked cases, we interviewed key informants, we interviewed social contacts. Then we come to a conclusion. We enrolled participants with fulfilling eligibility criteria over 18 years, at least one night outside of the study districts in past 7 to 60 days. So the enrolled cases were analyzed. We did key informant interviews, so where recommendations from in-country partners, recommendations from health facility during the training, and we found out then we went to referrals on the eligibility. The eligible cases were 45 among the 78 enrolled, and we did survey, but there were some limitations with the logistic barriers because social contacts all were not traceable and all were not in the geographical terrain where we targeted. And the residents of imported cases and their mobile migrant population social contacts, we found out 16 in Kailali, 13 in Kanchanpur, and 2 in Bardia, and analyzed further. On demographics, among the survey, only 49, and FGD 13, and survey plus FGD 39. So male was the dominant population, and Vivax was a dominant parasite group which were dominating. And many people were hardly educated and even simply able to write and read, which has up to primary education. So understanding is different. So we analyze on 4 themes: travel patterns, malaria knowledge and prevention, health seeking behavior, strategies for assessing high-risk MMPs for surveillance and prevention. So on travel patterns, if you see this zigzag map, not only one point, there are many places. It's not cross-border, it's inter-country travel between different states of India and people from Nepal. Few went to Gujarat, few went to Maharashtra, and others went to other states. So our concentration were mainly on majority, with almost 42% travel to Gujarat with between 4 to 5 months of average stay. Mostly they used to work on the factory, while in Maharashtra also average stay is 4.5 months, but major work is night guards. And they also worked on textile, hotel, and other industries. So the transportation they took is mostly public transport, and it took almost 3 days for them to reach to the destination. And when we asked the participants, one of the key informants mentioned that there is an open border, hence they migrate to different cities of India to live as migrant workers. They are living a high-risk life. So they understand. And these trips are related to work, looking at green pastures. So on seasonality and the travel groups, travel to India is not necessarily seasonal, but returning is, because 20% of the participants mentioned returning in the months of September or October for festival season, which also coincides with harvesting season. Companionship during travel takes the form of small groups, about 4, but depends on several factors, including security and convenience. Sometimes it is 1 or 2, and sometimes up to 10. And on knowledge, prevention, and perceived risk, 60% of the participants had heard of malaria, of which 35% are aware it is transmitted by a mosquito. And we asked, in your opinion, how can you prevent malaria? Few mentioned bed nets commonly used at home, but not during travel. Perceived risk factors at home, including working in the field, cleaning animal sets near the house, and going to the forest. And few mentioned perceived risk factors during travel often include sleeping on floor or outside with no bed nets. So they understand a little bit on the risk. And health-seeking behavior, low awareness of existing free services at public health facilities. Thus, many initially seek treatment from the private facilities. People will choose private over public hospitals, or will travel to India despite increased cost for a shorter queue and increased convenience. Low utilization of preventive services. Treatment is sought only when symptoms are severe. Treatment in India can be cost prohibitive, incentivizing MMPs to return to Nepal when falling ill. So these are health-seeking behavior related findings. And then we looked at strategies, what can work for assessing high-risk MMPs for surveillance and prevention of transmission. We looked at 3 points: peer referral, border screening, and venue-based screening. On peer referral, we started talking to people recently diagnosed with malaria, asked them who they traveled with, obtain their companions' contact information, interview companions at their homes or elsewhere. Will only work well if MMPs tend to know more one another and are in contact with one another. Having contact not only while traveling but also while back in districts is crucial for tracking and follow-up, because many people travel together but they may not have contacts while back in home. But on peer referral, participants seemed willing and receptive to share referrals if available, if able. In reality, challenging to obtain referrals from cases, but reasons were mainly logistical. The fact that MMPs often reside in remote hilly regions made them difficult to track for follow-up during our study period. On those who were referred, not in contact or no phone, there is geographical constraint, because they may say that this village in this municipality, the person's name may be different and may not be available. So these are constraints on peer referral. On border screening, it is ongoing, but the recent information shows that border screening positivity is less than 1%. Is it a good value for money? Low positivity, as many people may not present with signs and symptoms during travel. Huge number of people crossing the border every day, making it difficult to screen all. Open border with opportunities to use non-formal border checkposts, in addition to the formal checkpost where the screening could be done. So there is less than 1% positivity. So this is a big question when we discussed with participants and others. And potential distrust of border security officials or privacy concerns, inconvenience, unofficial border post, and venue-based recruitment. The strategy for venue-based recruitment, where we go to other places where MMPs may tend to gather or meet. Example, rest stops along the way, cafe, hotels, or tea shops where they stop. But the issue is lack of traditional venues that have historically worked for other populations. Few places identify where MMPs specifically tend to gather, either in study district, or along route of destination. But what they say is migrant workers do not have a specific place to gather or meet. There are no such places like camps or resting places so that you can find them. This is information by a key informant in Baldia districts. There is no as such camp. So recently in 2022-23, the country has piloted this integrated HIV/TB malaria screening program for the migrants. Screening in origin, transit, destination, upon arrival, different activities has been done. So the findings is this was done in 2 districts where 9%, Baitadi is a district where 9% population are mobile migrant, means absentees in the population. Acham is 19%. And we targeted this 2 POEs, point of entry, Gauri Fanta in Kailali and Gaddachoki in Kanchanpur district. Majority of the migration is peer-driven and seasonal still, and lack of services in transit for both inbound and outbound migrants at the point of destination. Comprehensive services in transit are required to rely information on the risk of the disease, importance of safe behaviors, early access healthcare services wherever there is need. Information and services for MMPs must be integrated as they are vulnerable to a wide range of diseases. Solidified the need of additional implementation research to solidify evidence-based dialogue and advocacy for cross-border collaboration between governments of Nepal and India. Local municipality ownership is essential for sustainability of the program targeted to repatriating mobile migrant workers. So the limitations is on recruitment, duration of stay, timing and locations of data collection. So the implications of mobile migrant populations or cross-border transmission is, this study is increased awareness is necessary and a priority. Scale up of health system infrastructure, including lab and staff, is needed. Timing of intervention and availability of malaria screening services is crucial. To locate the most MMPs, utilizing existing migrant labor camps and community centers for building awareness for disease prevention in India would be advantage, for which we need a continued collaboration between 2 governments, government of Nepal and government of India. And based on the findings, we did publish a paper in 2019 on designing malaria surveillance strategies for mobile migrant populations in Nepal, a mixed method study. Many of you are very much aware and might have gone through. And at the end, what is needed is improve people's access to health system, early access to diagnosis and effective treatment. Sensitive case-based surveillance and effective response system where system is capable of detecting any cases in health facilities or point of entry, and targeted interventions for mobile migrant population and repatriating workers, and availability of prevention tools at peripheral levels of the health system, where health system capacity is strengthening in bordering and targeted vulnerable areas is very important. With this, although we see that there is a huge mountain, difficult to try, if we walk with a difficult terrain with careful steps, we'll be able to reach to the summit. With this, thank you, and over to you. Thank you.
Thank you very much, Professor. So we'll take questions at the end, so we'll have Q&A. So just a reminder for participants to put your questions in the Q&A box, and you can click the little thumb to vote for which questions you want to be answered the most. Hopefully we'll have time to address a few of them. And then you can put comments in the chat. So we'll go to our next speaker, who is Professor Zhou Wang from NIPD in China. He's going to talk about application of innovative grid-based surveillance strategy to ensure elimination and prevention of reintroduction in high-risk border communities in China. Over to you,
Okay.
Professor.
Okay, thank you. Many thanks for the chair and the reintroduction of malaria in a high-risk border community in China. My study area focuses on the China-Myanmar border areas. My name is Do Quanwang from National Institute of Parasitic Disease, China CCC, based in Shanghai. And this is my outline. I would like to present through the following outline. So this is the background information, including malaria in China. As we all know, the World Health Organization awarded China malaria-free certification on June 2021. And despite this achievement, Yunnan province, located in the southeastern China, still face the big risk of malaria resurgence, threatening which risk the China malaria elimination efforts. And as we can see, a total of more than 2,000 imported cases during 2015, 2018 in these border areas. And also we know that Yunnan province belong to the GMS, the Greater Mekong sub-region, which share around 4,000 kilometers non-porous, natural, and barrierless border with malaria endemic countries, including Myanmar, Laos, and Vietnam. And Yunnan border, in addition, Yunnan border region is the most underdeveloped areas within China, and the local residents live in those far-reaching areas are at high risk for malaria infection, especially for those mobile and migrant populations who cross the border daily and through the informal or formal border screen, border cross pointers for business, schooling, or medical care. And about 30% of the nearly 3,000 imported cases in China every year are reported from this area, this high-risk China-Myanmar border area during the local high mobile population movement. And also, I would like to share the concept of the grid-based strategy. And this, the grid system is a very ground level governance strategy that reallocate administration resources at a neighborhood level and provide the necessary trainings to community members, and which originally come from 2003 SARS outbreak, SARS crisis, and is sustained and maintained by the local government in case of some special crisis risk. And this term, the term grid, was introduced as the lowest level of urban governance below urban communities, covering a small area around 10 kilo square meters. And this great strategy among mobile migrant population in the China-Myanmar border areas has played an indispensable role in promoting malaria elimination efforts, and implemented by multi-sector at the grid area and under the guide, including supervisor of local health facilities, residents, family, and community members that are active participants, involve these actions. And the grid-based strategy particularly support the tracking and timely identification of any potential importation or re-establishment of malaria transmission, among those high-risk populations in these border areas. And for our study design, this content include the mixed method study with a descriptive quality followed by a quantitative component, such as include the focus group discussion and screening-based statistics. And the qualitative study include informants with experience from grid-based strategy practice, such as program manager, community health workers, and medical providers. And for the quantitative study, mainly focus on the registered data in the local CDC and 16 township hospitals for the 7-year period. From 2013 January to 2020 December 31. So this is after the toward the malaria immunization, during the malaria immunization process. And also for our study, a team of 3 researchers, experts conducted the focus group discussion after obtaining the formal consent, ethical consent. Participants were informed the purpose before the data collection, and the focus group discussing around 90 minutes to 120 minutes, and 4 focus group discussing within 6 to 8 participants each time. A total of 36 participants for this focus group discussion. In addition, recorders in the local CDC and 6 township hospitals from 2013 to 2020, and including migrant mobile populations and risk population, and malaria case reports and case investigation, as well as reactive case detection. And all this data were summarized and verified and confirmed with the local key stakeholders, such as the township hospital and the local CDC, within 2 weeks of the completion of the field survey. And the overall system emerged from the focus group discussing related to 2 aspects. And one is operational mechanism of the grid-based surveillance strategy. And the second is the adaptation of the grid-based surveillance strategy in the local practice. And as indicated from this picture, the major functions of the grid-based management are effective operated migrant populations, such as identify high-risk populations or pre-screen for malaria testing, and taking some interventions to reduce the risk of malaria infections and timely detection of malaria cases. And these functions are achieved by institutions as well partners within a grand unit, such as community groups, village committee, and village clinic. And in addition, and according to the National Malaria Elimination Action Plan, during 2010 to 2020, township level health facilities are the lowest units that for malaria diagnosis, treat, and follow-up in China malaria elimination program structure. However, according to the results of the focus group discussing, when malaria incidence was high in these border areas, community surveillance, case management, and response activities were achieved, almost achieved to the grid strategy, engage the village doctors, village committee, and the community groups. And this table also shows the different practice before and after the implementation of grid-based surveillance. And this strategy still remains in practice through the successful elimination of malaria, as well as ongoing prevention of the prevention of the local transmission from the imported case. And the main results, as we can see, the application of the grid-based strategy allows for a more targeted, proactive surveillance approach based on knowing high-risk populations. The implementation of a grid-based strategy has increased the screening positive rate. Here we can see that this screen positive rate increased around 1–2% during 2013, 2015, to more than 30% positive during 2016 and 2020, before and after the implementation of grid-based strategy. And also we can see zero new local case for 5 years during from 2016 to 2013 in Tengzhong County. And I think for this grid-based strategy has acted a cornerstone of the community malaria case management in the Yunnan border area, which can particularly reach those high-risk populations to promote the malaria elimination efforts, as well as to consolidate the malaria elimination force in these border areas. And we really hope and this strategy could be useful and helpful, as well as scaling up in similar areas in the GMS area where the malaria elimination efforts are most needed. Thank you very much for your attention. Over.
Thank you very much, Professor. So we'll go straight to our next speaker, who is Lieven Benev as Program Manager for Malaria Consortium Cambodia. And he's going to talk about targeting forest goers, mobile and migrant communities, tailored malaria interventions by mobile malaria workers in northern Cambodia. So over to you. Thank you.
So a good day to all, and thank you very much, Professor Richard and the APMEN TechTalks for inviting Malaria Consortium to present the activities. It's much more a practical approach compared to the previous speakers, wherein mobile malaria workers try to target forest goers and mobile and migrant communities in northern Cambodia. Next slide, please. So quickly, the overview of the talk. So first of all, the points of care, National Malaria Program Cambodia, who are we targeting exactly? Who are key actors in this activity? What kind of activities they do, the areas covered, and do they really contribute within the National Malaria Program with their activities? Some challenges to share and the key messages. Please, next. So I'm happy that I could borrow this slide from the National Malaria Program. So it's really showing that there are the public health facilities, but also the community malaria workers. And these community malaria workers in Cambodia They bridge the gap in between the population at risk and the healthcare system. So they're really these bridge builders. Village malaria workers started already back in 2001. They are based in villages. They provide free and preventive tools, diagnosis, treatment, and they really focus on communities, villages at risk in forested areas or people going to the forest, sometimes also to migrant mobile population that is residing temporarily in the villages. And then the other part are the mobile malaria workers, and that's the focus of today. They provide the same full package of free tools, early testing and treatment, prevention, referral, but they are much more focused on new settlements, on sub-villages, people living in remote areas, really focusing on those people living in the forest ranges, forest goers, rangers, and especially the mobile and the migrant population. Next one, please. So MMWs are targeting the populations with an increased risk exposure. So the target for Cambodia is that by 25, all species should be eliminated. By 23, last year in December, there were 0 PF cases for the whole country. But what do we see is that these last cases are really remaining and are concentrated in those remote areas and forested areas among populations with a high risk exposure. So the challenge, of course, is that the group that we're talking about is very diverse. You have forest goers, you have rangers, mobile migrant population, border guards, soldiers in some areas who bring in their family, and they all have different activities, different movements, different behavior, but also sometimes different languages, local languages, different beliefs, different contexts. So we really need this community-based and flexible approach. And this is what Malaria Consortium is supporting through some of the mobile malaria workers in specific areas in Cambodia. Next one, please. So the key actor, as mentioned, is the mobile malaria worker. The mobile malaria workers that Malaria Consortium is supporting, guided by the national program, they are mainly working along the international borders. Most of them are forested areas, especially in the northeast of the country, but also sometimes in provincial borders, district borders, where there is no coverage by health centers, or the health center is too far away, or no coverage by village malaria workers or other points of care. All these MMWs are recruited from local communities, so they are at home, let's say. Even these communities might be mobile or migrant population. They are trusted. They have the knowledge of the movements of the people, and they often also know the local language, which is quite important to have access to some indigenous population in some areas. Mobile malaria workers are trained by the health center staff, and they test and treat all people. They test everybody who is at risk, anyone who is at risk for malaria, independent of fever symptoms. They are flexible in their locations for themselves. They can move around to the whole area that they are supposed to cover. But also, if we see a change in epidemiology, in context, in movement of people, sometimes we have to end some of these activities and remove or move the financial resources to another area where there is a bigger or a higher need. These mobile malaria workers are fully part of the national malaria program, so there's a lot of support and supervision also by the national program. Next one, please. Very briefly, the different activities that these MMWs are performing. Some of them work in malaria posts. This is a tent placed at entry-exit points of big forests or mountainous areas. The post has a presence of MMWs 7 days per week, and they give the full quality malaria services from prevention to test, treatment, follow-up, referral. Another group of MMWs are outreach mobile malaria workers. They live already themselves in very remote areas, and from that place, from that area, they can do outreach activities. Some of them do 5 days, some 7, 8 days, some 11 days with overnight stay, with not overnight stay. Overnight stay means that they can meet more people, because people are coming back from the deep forest to a central point where they camp often. And also some prophylaxis activities has been set up last year, especially focusing or targeting on PF. Co-travelers are tested, those who were at the same place, same time of assumed infection, and then active fever screening done. This is a result of the community dialogues that we organize, so that the local authorities, communities organize within their area. And the goal is, is to make sure that everyone in that specific area, specific community with fever should be tested for malaria. So this is the active fever screening. So there is a whole bunch of different and various activities, resulting as well that even the mobile and migrant population know very well their peers, these people who have the test and who have the treatment, and we can see that passive case detection now also shows up. We have people moving to the house or the place where the MMW is living, because it's much more nearby, it's accessible, and it's an easy contact with the MMW. So we have also quite some cases detected through the passive case detection. Next one, please. So briefly, you can see here some dots on the map of Cambodia. The red ones are the malaria posts, the blue ones are the outreach activities. You see much more activity in the northeast of the country, because these are the more, or were in the past, the more endemic areas. You can see the border with Laos in the north, really on the top at the right side. Much more activities there. Big forest covering Cambodia, linking to Laos. But as you can see, there's also interprovincial, quite a lot of, and interdistrict, quite a lot of areas covered. By the end of 23, 101 MMWs were supported by our teams at 82 locations. For the whole country, there were more under the national program. They do an average of more than 7,000 tests per month. 23 found about 134 cases left, only 2 PF, and then the positivity rate was 0.17%. So you can really see the huge amount of effort that they did to find those very last cases in those remote and forested areas. Next one, please. So what do we contribute? What do these MMWs, these mobile malaria workers, contribute to this national strategy of elimination? So we had a look at the 6 provinces where these MMWs are working and that we are supporting. So in 21, there were 85 MMWs working. And then we compared the number of tests and the number of cases found by them with the total number of all the points of care in those 6 provinces, meaning health centers, referral hospitals, health posts, VMWs and MMWs. And in 21, about 20% of all the tests in those provinces were done by these MMWs, and 18% of the cases were detected by them for the 6 provinces. In 22, we increased the number of MMWs because there was a light surge in the country of malaria infections, and then you could see that 24%, so almost 1 out of 4 cases in those 6, specifically in those 6 provinces, were detected by those MMWs in those specific remote and hard to reach areas. In 23, we increased again the MMWs, and then we had 15% of the tests done and 15% in those areas detected, cases detected. Next one, please. So when we look at, do we really target mobile and migrant population? Yes, we are based there. Where do we really detect them? We could see that only looking at the positive cases in 22 and then later on in 23, only looking at the positive RDTs, that in 22, 62% were mobile, and in 23, 60%. Mobile and migrant population is here defined everybody who is living or staying in that place less than 1 year. Whenever you are more than 1 year, you will be classified as local. So this is how the MMW asked this information to the positive cases to the patients. Next one, please. So there are some challenges, of course. One of the important challenges that we hear from mobile malaria workers is that now they are much more going into we are in the elimination phase in Cambodia in monitoring. So that means that for them as a community health worker, it's a bit less rewarding. The past they were proud how many cases they found. So we really have to find other ways to motivate them to find that balance in their volunteer work, but also make sure that costs are recovered and find different ways of non-material motivation, if I can call it like that. They will also have a bit more of a prominent role in the case follow-up, the case management, for example, for radical cure follow-up or the referral. And then very important is the integration of the role of MMWs and in broader perspective, the village malaria workers to other health needs. And here, the National Malaria Program, CNM, they developed a roadmap that started already a few years ago for the integration of VMW, MMW. So they have already a broader package of responsibilities where they could people inform, but this is on the longer term the idea and what the National Malaria Program will work on. Next one, please. So the two last challenges here mentioned, there might be more, but we made a selection, is the mobile and migrant population. They often ask different or they mention different health needs that are more important for them. So they question sometimes this vertical approach. Why do you come all the way and only talk about malaria, dengue, chikungunya, or do some deworming activities? Why not more? Again, the resolution or the answer would be integration of MMWs, expanding towards other health areas. But also very important what we see is because of the reason that MMWs are very much strongly trusted by that population, by mobile and migrant communities, and I really call them communities because they often make the link towards the existing public health facilities, which they often don't even know where they are or how to reach them. And the MMW often opens the door almost literally to make that link with the public health facilities. Last challenge is, of course, the reduced funding resources. If you move to elimination, resources often go down. So they need to be on the longer term to prevent reintroduction, to prevent re-establishment of malaria infections. There is a need for follow-up, for support on the longer term, and therefore this high-level commitment is really important, and the commitment of the authorities on national and sub-national level, and include them already in some meetings. And this is what's happening now, organized by the National Malaria Program and then the different provinces. Integration as well on the community level. What are existing community networks? How can we make sure that with declining funding resources that malaria is not forgotten, that it's still there, that it's somewhere still in the back of people's minds? Because if it's not there, then it will not immediately report it. And this is still the aim for the moment in Cambodia. Any single detected case needs to be reported within 24 hours and action taken by the health centers, the operational district, and the province. And the last definitely important one is the ownership by communities. If communities don't react, if they are not involved, then people will not go for testing or not alert people if there is any problem. So this we specifically in PV local transmission areas, we try to do through the community dialogues. And we can see that local authorities who are involved, who are leading actually these community dialogues, that they bring that information, that message, that objective of elimination, that they bring to their own existing community meetings. We gave them some tools, some simple pictures to explain very well and to motivate people to go for testing. Next one, please. So these is the last one, the key messages. So just to summarize, reaching forest goers and mobile migrant population, sorry, is an ongoing process, and this really fits with the two presentations that just came before us. We need those various adapted and tailored approach with a lot of flexibility. Reaching forest goers and MMPs, you need to engage the local communities and the communities because they are the driving forces for these health services offered. But at the same time, you need that strong commitment of the authorities on all levels, especially on the longer term, to prevent reintroduction. And then important is also to link those forest goers and the MMPs with public health services to integrate as well what is existing already. How can we integrate this work to make sure that it's not forgotten in the future? Next one, please. I would like to acknowledge the Ministry of Health from Cambodia, CNM, National Malaria Program, for our good and strong collaboration, and UNOPS, the principal recipient from Global Fund. Just the one slide, next one, to say thank you to you all. Thanks.
Thank you, Lieven. That was great. So we're going to move to the Q&A for all speakers. So if I can ask the presenters to put on your camera, please, and we'll go through in order. So first, Professor Gamira, thank you so much for your very active response to the many questions you've had in the Q&A. Maybe we just pick up on a couple. There were some questions about how cases are classified as imported or indigenous, which you responded to. But there was a request for a bit more information about how that information is collected. Is it through questionnaire? Do you use some other technologies as well in the portal?
Sorry, Eric, can you repeat that? How do we identify indigenous and imported cases? Okay. Yeah. It's through questionnaire, not through anything. Anybody who is a patient with a travel history within last 1 month, 30 days, outside of their original residence, it's considered as imported cases. And we do not see whether they have traveled to this place or that place, whether that place is endemic or non-endemic. And somebody traveling outside of the normal residence coming up with a fever and confirmed malaria microscopy is, or RDT, is an imported case.
Thank you. And is that on any spatial scale? So could it be the next district or the next village?
Sorry?
Is that on any spatial scale? So in the imported, could it be just from another village, or would it be another district? Or
now it's outside of the village. It's right. Maybe within the country or outside of the country.
Right. Thank you. Okay, Professor Wang, question for you. Okay. There's a bit of interest in whether you were collecting information on anemia, anemia risk status for migrant communities. A couple of people asked about that.
Not yet.
Professor Wang.
Okay, thank you. So question for me, just you mentioned, I don't think they have a special way to collect the information through the email. it will take more time because in China we have a very popular, widely used WeChat tool to communicate and to discussing. These are very popular tools to collect the real-time information if necessary. However, in the border area, in the China-Myanmar border area, we have a very strong and sensitive surveillance system. As you know, we have carried out the case-based surveillance model 137 model in the border area, particularly for the migrant mobile population. We also strengthen this surveillance is the potential malaria infections in the border areas. Thank you.
Thank you. So there was a couple of questions specifically about anemia, whether you collected information on that.
Yeah, that's okay. I think if they have some particular questions, they can share through my email, and I would like to respond one by one. Thank you.
Okay, thank you. Have you put your email in the chat?
Yeah, I already. I think I will share. I will share in the chat.
Great. Okay, Levin, a couple of questions on the costs and the payment for MMWs. So they're asking about what are the costs associated with testing, and then whether MMWs are paid. If you wanted to comment on that.
Yeah, sure. This is an integral. So the MMWs, I will, if okay with you, just answer some other questions at the same time, I think, because they're few recurrent. MMWs here that we support are an integral part of the National Malaria Program. So we are following a similar system as agreed for the village malaria workers, which some of them also do some outreach, but limited, 1 or 2 days. So the mobile malaria workers, if they are working at the malaria post, they get some incentive per day. It's like $5 per day that they are working there, plus their transport costs. And if they go to the meeting in the health center, which can be quite far for some live like 80 up to 100 kilometers from the health center that cover their area, they as well get a kind of per diem and then transport costs for the meeting. So in general, mobile malaria workers and VMWs get like $20 per month to attend the meetings because they go every month to the health center to get the commodities, and then they get some per diem if depending on the distance where they are. If our MMWs go on outreach, they get costs paid for the transport, and if they stay overnight, we also pay kind of a per diem. But they use their own motorbikes, so it's a kind of a balance. Use their own motorbikes, take the risk, and then some compensation through this incentive system of incentives. Yeah, if that's an answer.
Yeah, thank you. Maybe we can follow up. Just there's also questions about the next steps and whether there's plans to integrate MMWs.
This is so, as I mentioned a few times, these MMWs are an integral part of the National Malaria Program. So we fully support the National Malaria Program, and this is definitely something that is on the agenda for the coming years. So we just started the new cycle for the RI4 from Global Fund. So this is on the agenda for the coming years. If I look back in the past, when we worked with other MMWs where there was a need, these MMWs were in a way, although they were part of the national program, handed over to the national program. So this is definitely something that is under discussion for the coming years and the coming time, because if not, these areas, it will be difficult to cover them. But as I said, integration is most important. How to integrate an existing community networks supported and linked with the health centers. Like we have in Cambodia, the Village Health Supporting Group. How can we combine this? That's under discussion. Yeah.
Right, thank you. Maybe come back to Professor Wang. Are you still there? Yes.
Yes, please.
Yeah,
I'm
just
sorry, just a connection is not good.
okay. There's a couple of questions about more detail about designing the grid-based strategy, and you mentioned in the chat about the paper, but I wondered if you wanted to say a bit more.
Sorry, can you repeat?
Yes, so there's some questions about designing the grid-based strategy in more detail about how it was done.
Okay. So I would like to just share some details for this grid system. In fact, for this strategy is a very low-level governance strategy that reallocate administration resource at a neighborhood level and provide the necessary training to community members, and which originally come from the 2000 SARS crisis, and the term grid was introduced as the lowest level of the urban governance below urban communities, and covering a small area about 10 kilometers square, and a grid administered from the community and selected by the local community as part of the broad administration system, and monitor the community members, while at the same time provide service to the local communities. And this grid-based strategy relies on some techniques such as information sharing and following up evaluation of people's satisfaction levels, and connection with the local political legal agency, such as the local policy and custom, and wide administration systems. I think this concept of the low-level administration strategy approach. Thank you.
Great, thank you. Maybe, so our last question before we go to the poll to get feedback, I'll go back to Professor Gamiri. You've already responded in the chat, but the general question from Dr. Misra about are there any new ideas from the panel for a common strategy for cross-border malaria to mandate for countries to follow? So I wonder if you'd like to say a bit about what you think.
Thank you, Professor Richard. Thank you, Professor Misra, for bringing this question. It's very important when we sit in cross-border meetings or inter-country meetings, we tend to agree in principle that we agree to share data, but it has never happened in regular time, not even on cases, interventions, and any harmonization that is required for controlling those things. And as you might have seen in my presentation, the cases come from one particular state down in the south and coming to the Nepal, and sharing data among two states is not any implications on control measures. So this should be aligned, and as far as possible, strategies should be aligned. And if and when there is a regional mechanism which is effective to get those information, what is circulating in part of Nepal or part of India or part of other countries, if that could be aligned and regular actions could be taken, that will be excellent. So we have to bring some regional players to play in this, and countries to open on the disease and intervention database. It's not a real security question, but it's a health security, so it's a concern of all. Thank you.
Thank you so much. Thank you very much to our panelists. We are going to move to a poll just to ask for feedback from participants about the Tech Talk webinar. So hopefully there should be a poll popping up on your screen. There we go. So I'll just leave a bit of time for people to respond to that. Right, it's starting to slow down. So last chance, few seconds. That's a nice feedback. Great, and also we've also taken note of the comments in the chat. So any final suggestions or comments, please feel free to post them. But in the meanwhile, I'd just like to thank all of the presenters and all of the participants for joining this Tech Talk webinar. There will be another Tech Talk. We take account of your feedback. We'll be announcing quite soon with a new call, and we're also sending out our monthly newsletter where it will be announced there as well. So with that, we will end the poll and we will close the meeting. Thanks, everybody.
Thank you.
Thank you.
Thank you.
Have a good day.
Thank you. Bye-bye.
Bye.
Bye. Bye-bye.
Bye.